Now we will discuss the next subheading in the topic hypertensive disorders complicating pregnancy. It is end organ damage. Okay. So 3 to 4 MCQs are there in this end organ damage, out of which most commonly involved organ is kidney. Okay. Kidney is the most commonly involved organ. So what are the lesions associated with preeclampsia in kidney? Number 1, there is decreased renal perfusion. Okay. There is decreased renal perfusion. There is decreased GFR, decreased glomerular filtration rate, and the pathognomonic lesion associated with preeclampsia is glomerular endotheliosis. Okay. This question has already come in all India exams. The pathognomonic lesion associated with preeclampsia in kidney is glomerular endotheliosis. Very important MCQ. Glomerular endotheliosis is the characteristic. Kidney is the most commonly involved organ and glomerular endotheliosis is the characteristic lesion associated with it. Okay. Apart from this, the other changes are decreased urinary sodium concentration, decreased urinary sodium concentration, okay, increased urine osmolality, increased urine osmolality, increased urine plasma creatinine ratio, increased urine plasma creatinine ratio, and as I already told you, hyperuricemia, hypocalciuria. It was proposed that low calcium reserve in the body leads to low calcium excretion in the urine, and low calcium reserve in the body itself is a predisposing factor for preeclampsia, and therefore when you excrete low calcium in the urine, it indirectly tells you that the calcium reserve in the body is less. Okay. Hypocalciuria and acute tubular necrosis. Okay. So decreased renal perfusion, decreased GFR, glomerular endotheliosis, decreased urine sodium concentration, increased urine osmolality, increased urine plasma creatinine ratio, hyperuricemia, hypocalciuria and acute tubular necrosis. These are the changes in the kidney. Next we will discuss something about the changes in the liver. Liver changes are: number 1, periportal hemorrhage, and number 2, subcapsular hematoma of the liver. Okay. Number 1, periportal hemorrhage, and number 2, subcapsular hematoma of the liver. Okay. These are the two important tissue changes in liver. Next, about brain. In brain, we have a very important condition called posterior reversible encephalopathy syndrome. We call it PRES. Okay, PRES. So what is PRES? PRES is posterior reversible encephalopathy syndrome. Posterior reversible encephalopathy syndrome. What is it due to? PRES is due to sudden hyperperfusion. Okay. PRES is due to hyperperfusion. PRES is due to hyperperfusion seen in the brain, and most commonly it involves, as I already told you, occipital lobe. Okay. It more commonly involves occipital lobe. Okay. So PRES, posterior reversible encephalopathy syndrome, very important MCQ. PRES is a complication of preeclampsia. PRES is a complication of preeclampsia. And which lobe does it involve? It involves occipital lobe, okay. And what is press due to? Press is due to hyperperfusion, okay. So what are the other changes in brain apart from this? We have cortical and subcortical, cortical and subcortical petechial hemorrhages, cortical and subcortical petechial hemorrhages, okay. So headache and scotoma as a result of brain involvement, headache and scotoma as a result of brain involvement, okay. So these are the end organ changes associated with the preeclampsia. So again I am telling, most commonly involved organ is kidney, and the most common lesion is glomerular endotheliosis. Most pathognomonic lesion is glomerular endotheliosis, okay. Apart from this, liver, we have periportal hemorrhage and subcapsular hematoma of the liver, and this is the cause of epigastric pain. This is the cause of epigastric pain. So in brain, the characteristic lesion is press, which lobe? Occipital lobe. And what is it due to? Hyperperfusion, okay. Press is posterior reversible encephalopathy syndrome, okay. So this is about the tissue changes. Next we will discuss about prediction and prevention, okay. What are the predictors, proposed predictors? What are the predictors which were in use, and now what all predictors have been disproved, okay. So under predictors, we have a list of predictors here, out of which the first three are alike. They are: number 1, rollover test, okay. Number 2, angiotensin sensitivity test, and number 3, isometric exercise test, okay. We have rollover test, angiotensin sensitivity test, and isometric exercise test, okay. So what is this rollover, angiotensin sensitivity and isometric exercise test? What's the common point between these? We do something to the patient, or we give some injection to the patient, and we ask the patient, we measure the diastolic blood pressure before and after the intervention, okay. So what do we do in rollover test? We put the woman in left lateral position, measure her blood pressure, and then we turn the patient to supine position, then measure her blood pressure. Which blood pressure are we worried about here? We are worried about diastolic blood pressure, because diastolic blood pressure determines the outcome of pregnancy. And between these two positions, the left lateral and the supine position, blood pressure should not vary by more than 20 millimeters of mercury. Blood pressure normally tends to increase when you change the patient from left lateral to supine position, but this increase should not exceed 20 millimeters of mercury. And if there is an exaggerated increase when you change the posture, then this becomes a predictor, or this pregnancy is at risk for preeclampsia, it means, okay. So which blood pressure do we measure? Diastolic blood pressure, and the cutoff is 20 millimeters of mercury, okay. So this diastolic 20 millimeter cutoff is applicable for the other two as well, that is angiotensin sensitivity test and isometric exercise test. So in these two tests, what do we do? In angiotensin sensitivity test, we first measure the blood pressure without giving angiotensin, and then give a dose of angiotensin, IV dose of angiotensin to the patient, again measure her blood pressure. Now there shouldn't be an increase in the diastolic blood pressure by more than 20 millimeters of mercury. Similarly, in isometric exercise test, we give a smiley ball to the patient and ask the patient to press the smiley ball. Check the blood pressure before pressing the smiley ball and after the smiley ball. Now, if the blood pressure increases by more than 20 millimeters of mercury after doing this isometric smiley ball exercise, then it means that pregnancy is at risk for developing preeclampsia. So all the three are just the same, okay. The first one, you change the posture. In the second one, angiotensin sensitivity, you inject angiotensin, and in the third one, you give isometric exercise, okay. So this is about older tests that we were following. Now, what is the ideal gestational age to do these tests, rollover, angiotensin sensitivity and isometric exercise test? It is 28 to 32 weeks, okay, 28 to 32 weeks, and they were able to predict preeclampsia with a reasonable sensitivity of 50 to 75%. Okay, they had a reasonable sensitivity of 50 to 75%. They were useful, but we were not satisfied with these tests because it predicts preeclampsia only between 28 to 32 weeks of pregnancy. Rather, we want some tests which can predict preeclampsia in the first trimester or in the early second trimester, or at least in the late second trimester and not in the third trimester, whereas 28 to 32 weeks is third trimester. Okay, so we wanted tests which can predict preeclampsia a bit early. Okay, so apart from these, what are the other available tests to detect preeclampsia? Next important test that you have to know is uterine artery Doppler. Okay, uterine artery Doppler. So, what is this uterine artery Doppler? When we usually put Doppler for any vessel, in obstetrics we are worried about umbilical artery, uterine artery, ductus venosus and middle cerebral artery. We have a picture like this for uterine artery in the first trimester. Okay. So, what does it mean? It means that this is the amount of systolic flow, this is the amount of diastolic flow in the early diastole, and this much is there in the late diastole. Okay. So, you can see that the systolic flow is constant throughout, whereas the diastole is divided into early diastole and late diastole. And you can also see that in the early diastole the blood flow is little less, and in the late diastole the blood flow is picking up. Okay. And now remember, this kind of an early diastole and late diastole variations are seen only in the first trimester when the second wave trophoblastic invasion has not yet occurred. Okay. Now, in the second trimester, we all know there is something called second wave trophoblastic invasion. Second wave trophoblastic invasion, and I already told you, once the second wave trophoblastic invasion is over, the spiral artery penetrates deep into the lacuna, and because of this, more amount of spiral artery, more segment of spiral artery relaxes, the pressure drops, resistance drops, blood flow improves. So, after the second trimester, after the successful trophoblastic invasion, the difference between early diastole and late diastole disappears, and the picture becomes something like this, where this is systolic flow and this is diastolic flow. Okay. So, what happens? Early diastolic notch, that means the notch which was there before trophoblastic invasion disappears. Okay, this notch disappears after successful trophoblastic invasion. So, we were using this as a predictor of preeclampsia. The uterine artery Doppler is supposed to be done at 24 weeks. Okay, it is supposed to be done at 24 weeks, and it was said that if this diastolic notch persists, persistence of early diastolic notch, okay, persistence of early diastolic notch is a predictor of preeclampsia, but now they say early diastolic notch is more a predictor of IUGR than preeclampsia. Okay, so now they say early diastolic notch, though it talks about the implantation, though it talks about the fall in the resistance and the blood pressure, it only predicts IUGR and it does not predict preeclampsia. So, very important information, remember, it only predicts IUGR, it does not predict preeclampsia. Okay, it does not predict preeclampsia. Fine. Okay. So, this is about uterine artery Doppler. Fine. So, the next one is few important markers like substances in the serum like HCG, PAP-A, inhibin, okay, inhibin, activin, okay, procalcitonin, procalcitonin, okay, kisspeptin, corticotropin releasing hormone, okay, and these are substances which are studied for this purpose, okay, which are studied for prediction of preeclampsia and were found not useful, okay. These were found not useful. So, uterine artery Doppler is only a predictor of IUGR and not preeclampsia. Similarly, these substances were studied and they were not found useful for the prediction of preeclampsia, okay. So, the next one is uric acid. Uric acid is a well-known predictor of preeclampsia. As I already told you, hyperuricemia predicts preeclampsia because uric acid is a marker of cellular turnover. More placental turnover or more hypoxia in the placenta is detected by, is marked by high levels of uric acid, okay. So, uric acid is a predictor of preeclampsia. Next one is microalbuminuria. Okay. Next one is fetal fibronectin. Okay. Next is cell-free fetal DNA in the maternal serum, cell-free fetal DNA or maternal serum free fetal DNA, okay. And next is soluble FMS like tyrosine kinase, or the ratio between soluble FMS like tyrosine kinase and PIGF, okay, the ratio between soluble FMS like tyrosine kinase and PIGF. These were the 10 important predictors that were studied for preeclampsia for the use of prediction, out of which few were found useful, few were found not useful. I will tell you what all are useful. Whatever I am marking in green are useful. So, rollover test, yes. Angiotensin sensitivity, yes. Isometric exercise, yes, useful. Uric acid, microalbuminuria, useful, and soluble FMS like tyrosine kinase is coming up as a promising marker now, okay. Others are not useful. As I already told you, uterine artery Doppler is only for IUGR and not for preeclampsia, okay. And other serum markers like HCG PAP-A are not useful. Fetal fibronectin, cell-free fetal DNA are found not useful for the prediction of preeclampsia. AIIMS aspirants, please you have to know this, okay, you have to know this because they will ask in AIIMS, okay. So, these are the predictors of preeclampsia. Before we go into the management part, we will discuss about the preventive agents, okay. So, what are the proposed preventive agents for preeclampsia? Prevention, very important area. Prevention. So, I am going to tell you 12 important substances which are tried for the purpose of prevention, okay, tried for preventing preeclampsia, and I will also tell you which works and which does not work, okay. So, number 1 is low salt diet. Number 2, calcium supplementation. Number 3, fish oils or omega-3 fatty acids. Number 4, regular exercise. Number 5, bed rest. Number 6, smoking. Number 7, diuretics. 8, antihypertensives. Even before the lady develops hypertension, if you treat with antihypertensives, will it work? That is the question here. Number 9, antioxidants. Number 10, statins. Number 11, metformin. And number 12, aspirin and heparin. Aspirin and heparin. Okay. Now these many proposals are there. Many of them have been, all the 12 drugs have been tried, or 12 techniques have been tried. Okay. Now what all works and what all doesn't work, we will see. Low calcium, low salt diet is proven ineffective. Okay. Calcium supplement, proven ineffective. Fish oil, it's proven ineffective. Okay. Regular exercise is promising. Okay. Bed rest is promising. Smoking is promising. Okay. Statins, yeah, promising. Metformin, promising. Aspirin, heparin, definitely promising, and that too aspirin combined with heparin for the treatment of APLA, antiphospholipid antibody syndrome. Okay. Aspirin plus heparin is promising for APLA. Okay. So these are the promising ones. Diuretics and antihypertensives have no role in preventing preeclampsia. Okay. So what all had lost its hope? Low salt diet, calcium supplementation, fish oils, diuretics, antihypertensives, all these were tried in the past and now they've all been proven ineffective. Okay. Bed rest, exercise, smoking, statins, metformin and aspirin and heparin. Aspirin definitely has a role. When you combine it with heparin, it works well for APLA. Okay. So this is about prevention of preeclampsia.